Good morning, everyone. Thank you for being here. I am a long-time follower of Parkland Institute of Political Economy since I arrived to Canada 15 years ago. And then I did my PhD in political economy, and I'm now very proud member of the board of the Parkland Institute, and so happy to be here for the first time. I am newcomer to Alberta, and I've been very impressed with the beautiful people, leftist, progressive people who are been attending this conference. And so I am very happy to introduce to our speaker today. She's Ginetta Salvalaggio, and she's going to talk to us about disinformation, the first step in dismantling systems of care. Ginetta Salvalaggio is a professor with the University of Alberta, particularly with the Department of Family Medicine, where she's Associate Scientific Director with the Inner City Health and Wellness Program. Ginetta is going to talk to us about the Alberta disinformation formula that is being used by conservative politicians to confuse the public about issues around health as a formula to dismantle or to question the validity of research, discovering scientific research. And so she has a lot of experience working with people using drugs in Alberta, and will use that experience to walk us through this disinformation formula. Welcome, please, to Ginetta Salvalaggio.
Hello, bonjour, tanse, to everybody who is listening online and in the room this morning. It's a pleasure to be here. Before I do anything else, I would say this is not my area of expertise. I just was a little old family doc, just minding her business with her head down, occasionally doing research. I had to pay attention to this, but it turns out, and my husband tells me this, it turns out that actually this is our expertise. This is our fundamental expertise as family physicians trying to help people navigate through very complex information. So let's own it together, shall we? What I'm going to speak about this morning is going to hurt a little bit. So I just want to honor that for those of you in the room who are struggling with some of the things I'm going to be talking about. Those of you who have lost someone you care about, colleague, friend, family member, I see you, I care for you. I'm going to start by humanizing some numbers that I necessarily have to speak to, but I just want you to know that we're not out of this, despite what others might say. So please, if you want to just unpack this quietly later, I'm more than happy to chat with you about it. I do need to acknowledge a lot about this territory and how colonial actually the conversation we're going to have really is. My acknowledgement is I live and work in Amiskwaciwâskahikan. This is the Nehiyaw word for where we live. Beaver Hills House, and I think it's important for us to invoke language. It is the literal translation of Edmonton. It is located in the northern prairies of Turtle Island. Many people have been here gathering in this place for time immemorial. I'm really grateful that we're gathering together, but it goes beyond gratitude. And I want us to think a little bit about how disinformation is intended for control, it is intended for dispossession, it is intended to take people's data and take people's stories away from them. I think it's really, really important for us to situate this within a colonial narrative as well. On the right, I like to invoke the wheel of privilege and power and think about how essentially privileged many people in this room are. I find myself very close to the center of this wheel most of the time, and I do feel that it is my job in that space to disrupt. But I do want you to think about how do you lean into those margins and understand those margins and ensure that they get platformed in the public narrative. It's not just our stories and our experience, but it is ensuring that people without power and privilege also have the honor and privilege of having their story heard. I've been labeled, as have many of the people in this room. I wear this label with a badge of honor. These are photos of why I do what I do. On the bottom left, people I care about, many of whom have passed away to a toxic drug crisis, but who've informed a lot of my academic work. So I just need to honor them because they have informed what I do. They are my teachers. They are my mentors, and they're still there with me. You will see letters written to prime ministers by bereaved mothers. On the bottom right, a space of healing and love that was dismantled and perceived as a threat by the rest of society, and these spaces are still perceived as threats. You will see a building that has a space, a healing space, across from Rogers Place that taught me half of what I know that no longer is standing. These are the things that keep me going. These are the people, they're still there. All of these lessons, all of these stories, and they hold me up. We've lost a lot, but we haven't gone away. And I know you all have stories that got you to your radical activism. So I just want to hold that before we get into numbers. But to fully understand this crisis, we do need to unpack the data. Well beyond reported overall case counts. So opioid poisonings are a leading cause of death and disability in Canada for the past several years now. We started to notice a blip in 2016 upwards. And in retrospect, it was such a tiny blip, but it was alarming at the time. And it's just become, with fits and starts, ever greater. Opioid poisonings are the leading cause of death and disability in Canada. The scope is comparable to the recent impact of COVID-19. Non-fatal poisonings can also cause long-term things like brain injury and other sequelae that we have to talk about, and we have to acknowledge that we have a lot of survivors. Deaths are premature, and they're preventable, and they're now outpacing all other causes of death as far as years of life lost in otherwise young, full of promise folks. In jurisdictions across North America, life expectancy has been decreasing, and it is contributing to the excess deaths we are seeing in Alberta more generally, or have seen in Alberta more generally at the beginning of the pandemic. More on that later. And of course, this is going to have an impact on the health system. So our first responders are heavily affected as well, and firefighters have told me that they start their shifts with 3 naloxone doses ready to administer in their pocket. So those of you who are on the front lines, and we heard a lot of you, this is demoralizing when you're going to work and you know that you're going to see a case or 2 or 3 like this. So I'd like to turn your attention to how this impacts all Albertans, for sure, but the impacts are uneven. Many neighborhoods are affected, and there are some neighborhoods that are grieving far more than others. And this matters when we're going to talk about some of the interventions that have evidence in a moment. And yes, the majority have traditionally been in private residences. There was an early narrative about people using alone, et cetera, and yes, unfortunately, that still happens. But the houseless are disproportionately represented. The orange, those are deaths in public spaces. And most of those folks are houseless. Note that I use houseless, by the way, not homeless, because an encampment is a home. So I just have to be very clear about that, and because land is home for Indigenous cultures. So there's almost nowhere safe to go. People aren't allowed to exist in public spaces, as we've seen with some bylaw conversations. I responded to poisonings in my clinic washroom, on my cycle commute, on bus benches, shuttling my kids to activities. First Nations people represent less than 5% of the Alberta population, but they represent 24% of all opioid poisoning deaths in 2022. First Nations people are also experiencing a disproportionate year-over-year increase compared to the general Alberta population. Each person who dies is grieved by their families and their communities, and many communities are experiencing the cumulative grief and trauma of losing multiple members with the subsequent impacts of that trauma on health. And that is well established. Many of you have heard about the link between adverse childhood experiences and general trauma on your well-being and health later in life. Now, these data are from BC, but they're consistent with studies in multiple jurisdictions and in an earlier systematic review. But I highlight it here to say that in this particular study, but it's parallel with others, that people who have been just released from an institutional space where they may have experienced a period of abstinence, voluntary or otherwise, within 2 weeks of release, this is jail data, but within 2 weeks of release, they're at 50-fold higher risk of death compared to the general population. This one here is about the story about prescription opioids, which is another narrative you'll hear a lot about prescriptions and my prescription pad being the problem. So I came of age medically in the late 90s. Maybe I can say that there might have been a contribution or an issue at that time. There was a lot of narratives around prescribe more. It's 2024. You will see the blue is non-prescription opioids. What is driving this drug toxicity crisis now has nothing to do with my prescription pad. People talk a lot about fentanyl and carfentanil, but notice how many people who use stimulants, in particular meth, are affected. In both Ontario and BC now, there are publicly available reports that demonstrate that possibly up to a third of poisoning deaths have no evidence of an opioid use disorder before the time of death. And it's because not everybody is engaged in problematic substance use who is at risk of this condition. And when we think public health, you have to think about what are you targeting here? And it's fair that some people are at risk in part because of an opioid use disorder, but that's not the only risk factor. And note that there are a lot of other contaminants that are contributing to fatalities now as well. I've seen a lot of tranq dope, I've seen a lot of benzo dope. There's a lot of these contaminants now that are coming into play that make our traditional ways to reverse an overdose harder and harder and harder to use on their own. So because this is a complex problem, we need comprehensive, multi-component, interconnected solutions. That's just evidence-based responding to a public health emergency. And this is fully consistent with a decolonized view of health as well, I might add. So, harm reduction. This is an evidence-informed approach. This is why it's part of a comprehensive response. Because the proximal cause of death is a toxic drug supply. Let's address the toxic drug supply. And this is why we have take-home naloxone. And I dare say that Edmonton was a North American pioneer when it came to take-home naloxone. So kudos to some of my mentors who got us to this point. Supervised consumption services. We'll talk about that in more depth here. But there's a lot of other emerging risk reduction strategies that do matter, that have value, that help keep people alive, and I dare say well. And if seeking treatment voluntarily is part of that, wonderful. So supervised consumption sites matter because they're evidence-informed and they keep people alive, full stop. That's the most important role they have. They are primarily used and needed by people who have nowhere else to go where they can use with someone else, with some supervision. So it prevents all those deaths alone. And it provides some trained personnel to support and monitor in a safe space that isn't outside, that doesn't contribute to a rushed use in an alley somewhere so that you're not discovered by police or by other people who walk by. It is a space of healing. It promotes getting people the health and social care that they need. It does not increase crime or public disorder. So why then are we witnessing this? Within a few months into the pandemic, after a specific SCS panel report was released, we started seeing the closure of publicly funded SCS sites, first in Lethbridge, and then later on into the pandemic in central Edmonton. So on what basis? These are evidence-informed strategies. We have a disinformation formula going on in our province. So I became involved in advocacy more than I ever have before, not only because I was losing people I care about deeply, and also losing people who were my patients, but I was also really, really alarmed as a scientifically trained human being that narratives were shifting to the point where we were getting into decision-making that was not based on evidence, and that we were going to ideology-informed decision-making and ideology-informed evidence-making. So let's talk about that a little bit. What are the key ingredients of the disinformation formula? In no particular order, suppress public data, sponsor pseudoscience, block science, and spread the narrative. How does one suppress public data? And I'm sharing some examples. These are only a few examples, right? There's so many more, but I'm just sharing a few salient examples. You remember those heat maps I showed you earlier about how some neighborhoods are more affected than others? And this is actually, those neighborhoods are where we had SCS. Those neighborhoods had SCSs based on good, hard data to suggest this is where the need was the greatest. Now we start shutting down SCS, and we're actually suppressing the data to understand where the greatest need is in tandem. On the right, this was a Freedom of Information request. It required a Freedom of Information request in order to get at data, and a year after they stopped supplying neighborhood-level data. You'll notice how many of the neighborhoods are redacted, but it suggests to us that there's just a lot of effort at just suppressing what's actually needed, patting ourselves on the back that things are getting better because we can't get at the data. Another thing is that we also have an overwhelmed medical examiner system. So there's data lags introduced. And that is used as a reason or a justification for an underreporting of deaths due to drug poisonings in our province. But as Tara Moriarty on the left describes, you would expect then, if it's just a matter of lags and so on, that those would be rectified before several years go by, and they have not. And the excess, the underreported drug poisonings in our jurisdiction, based on her modeling, is around 25%, whereas in BC it's only 10%. So what's going on there? How are things getting defined? Sponsor pseudoscience. This blew up in my face. I was trying to have this really quiet little sabbatical last year. This got published while I was supposed to be off. You will probably recall, some of you may have been to the town halls in that 2019 era, that lovely bygone era pre-pandemic, where there were a bunch of town halls and there were a bunch of online surveys and a bunch of written contributions to this SCS panel. They were reviewing the socioeconomic implications of having supervised consumption sites in Alberta. They were very explicit at the outset that that's all they were reviewing. They were not going to look at health outcomes. They did, however, talk about in their report a few things, like about we strongly suspect that people's opinions are slanted and people seemed very adversarial, and they started painting people who had a differing opinion to their own narratives as being suspicious and unreliable. You'll see that written all over the report. It's a fantastic read. It is a fundamentally flawed report for a variety of reasons. There were a number of biases that my colleagues and I uncovered, things like outcome reporting bias, confirmation bias, measurement bias, and we can talk about these a little bit more later if you like, and a lack of peer review. And then this science, this pseudoscience, got parroted out and used across multiple jurisdictions and used, frankly, to justify subsequent actions. So they sowed the seed of doubt very expertly here because people don't read the entire report. Meanwhile, more recently, we're seeing a lot of attempts to block science. There are people who have attempted to speak out about decisions, who have had their grant funding, their service funding threatened as a result or taken away. So you can't speak out if you disagree. We've all heard about Bill 18. This really matters. The General Faculties Council at this institution put out a strongly worded letter about how this is going to create fear and distress among the academic community. Many of us may walk away from this province, but much of our research may be questioned if there is this provincial priorities, political interference on what we're allowed to say and do or get funded for in this province. And I will remind folks that our Premier specifically invoked substance use research in her examples of things that may not match provincial priorities. And I know a lot of you are working on climate and reproductive and gender rights and everything. I mean, obviously, substance use isn't the only file, but she specifically invoked substance use. Okay, number 4, spread the narrative. We talked about Recovery Alberta yesterday briefly in the Q&A. Part of Bill 17 wasn't just the introduction of Recovery Alberta as one of those 4 post-AHS, I guess, pillars within healthcare delivery, but it also introduced this Centre of Recovery Excellence, which is a research entity. Now, I really raised my eyebrow with that. Now, we've got this government-sponsored research think tank that is with a very, very narrow focus just around recovery. My concern as a scientist is that it has all the setup of being a bit of an echo chamber. On the CORE's webpage, rather than just an about us, they have our founding story. And it just smacks of, populism and everything else. And I just thought this doesn't feel like a scientific outfit at all. They've also put their message out in the form of heavy presence at conferences, at recovery conferences, where harm reduction will not be named at all. They've also gotten themselves out into the media, sowing the seed of doubt again, saying, well, we're going to let the public decide, because that feels good to the public. We're going to let the public decide about the fate of harm reduction. With those 4 ingredients, we have an ultimate goal, and we're seeing it happen. We're seeing it play out. I spoke to those 2 first closures of supervised consumption sites a few years back. Look at what's happening this year. Down the road from us, we don't have a Boyle Street operated wolf den, Strathcona Health Hub. Perhaps might be considered the most progressive riding in the province. We can't open up an OPS. During the proceedings and the appeals, that report was cited. It's broken my heart because I'm very nearby. We have misattributed the root cause of social disorder and decided that it is SCS that causes social disorder because of a faulty report. Reallocate funds to the wrong things, to the things that create less safety, not more safety, for everyone, particularly for people who find themselves at the margins of that wheel of power. We block new services. We decommission existing sites. Some of you will have heard about what happened to the Red Deer OPS earlier this year. And then these are policy shifts that are happening in other jurisdictions as well. Other provinces, this is a gift for them. They're like, oh, I'm going to use this report and it's going to justify what I do, and it's going to justify my defunding of harm reduction. And at the federal level, we're seeing it as well in the policy narratives. Okay, lather, rinse, and repeat. We are not just talking about the SCS story, which is the one of which I'm most familiar, but here's another harm reduction story. We can tell this same story all over again. We have evidence of government-sponsored, methodologically flawed reports and a special select committee in which certain voices are amplified to then produce a very official-looking report that isn't peer-reviewed, to then justify sowing, as my colleagues in the East are talking about, sowing a moral panic, sowing the seed of doubt among the general public that safer supply is killing our kids. Honestly, there's so few people who have access to safer supply, I don't know how it could happen. And then ultimately, we then create legislation where it is now illegal, even though it was never officially a thing here, it's illegal formally for anyone in this province with a prescribing pad to even think about prescribing short-acting hydromorphone or similar in someone who has an opioid use disorder at the risk of thousands of dollars per day per patient. And it is also a situation where within that legislation, people who may have been on these short-acting opioids are told you have to go to a very specific place, a very specific clinic, and a very specific location, and you have to be transitioned off, ultimately disrupting relationships, caring relationships, which is also very heartbreaking for me as a primary care provider. Housing. This is a less parroted report, actually, but it did come out mid-pandemic around a recovery-oriented housing model. And I just love how people co-opt terms that are traditionally associated with very positive things, but have become really, really dividing in the community now. It's dividing to talk about recovery, because what do you mean by that? But the recovery-oriented housing model report came out. I just quietly put the names of the two co-chairs, which you can read for yourself there. You may ask yourself, are there conflicts of interest within this committee? In their preamble, they write, there can be no wellness without safety. Yet ideological debates have led to encampments. Ideological debates have led to encampments. Right? Criminals are preying on people. So this is before they actually write what they learned. This is in their preamble. This is the bias that they're introducing to the conversation. Random acts of violence, ruined businesses, on and on and on. You can go and find that report if you like. It's also a very good read. It's very troubling. Some of their outcomes were lots of solutions. It sounds good on the surface. Yes, we need all of this. We need, like, they talked about permanent supportive housing. They talked about increased capacity to house folks. But encampments are not the solution, was one of their outcomes. That's fair. Encampments are not perfect, but encampments create such community and beauty and healing space for people who have nowhere else to go, and there really is nowhere meaningful to go. And all the investments that we have seen, there's been some investments in permanent, but a lot of the investments we've seen have been in temporary shelter spaces. Shelters are not a safe place to go. And they are not supposed to be a permanent place to go, and that's what they have become. I've shared this with a few folks in the room, and without getting into their story for privacy reasons, I've been trying to rehouse one gentleman for 4 years now. And you get to the front of one line, and then you're too high functioning, and you get to the next line, and you're too low functioning, and you just get completely ignored as a human being, and relying on shelter bed for 4 years. So that's not okay. We're creating decisions based on very biased information. We are suppressing data. We're looking at the wrong data. We've seen the navigation centers. We're suppressing data about actual outcomes from those nav centers. So many people served, so many people referred, tick. Nothing is happening at the end of the day. But the model looks really good because of those metrics, and so now we're going to spread the model without actually investing in what actually people need. Meanwhile, we are witnessing in healthcare horrific things like amputations and so on. We have seen court cases get dropped on technicalities and people moving in saying encampments are not the answer, and completely dismantling things, and then there are expected consequences from that. Okay, people lose all their stuff, people lose access to their systems of care. You're going to be at higher risk of drug poisoning, you're going to be at higher risk of missing out on your methadone meds, you're going to be at much higher risk of an amputation in the middle of a cold snap last winter. The other data suppression, of course, is that we don't have a government who is owning up to how many people are actually houseless. One more for you. There's so many of these. I could do climate, I could do CPP, I could do gender care, I could do all sorts of things, right? I could do, and stay tuned, I probably will do the whole involuntary care thing, because that's coming next. Lather, rinse, and repeat, COVID-19. I love what Jason Markusoff had to say here in the small print. He's like, he's authored 2 reports on COVID-19. One of them is nonfiction. Many of you are familiar with the Manning Report, also known as the Public Health Emergencies Governance Review Panel. I just love that they invoked evidence and science in their report, bringing science to bear. A key question is how to bring science most effectively to bear without ensuring that science is not used to justify positions and actions rooted in something else like political expediency or ideology. Such hypocrisy. And now, in the midst of general suppression of COVID-19 narratives about go get your shot, here's what to do during the respiratory virus season, less difficult accessing numbers about how many people are actually ill, your inability to test. So we got all that data suppression. We've got this lovely report. We're platforming people with very out there ideas and deplatforming people who are scientifically trained, who kind of meet the consensus of like, you know, what we know about COVID-19. And we start introducing bills of rights. We must be vigilant. Scientists are a threat, clearly. We must be vigilant. We must be vigilant against people who suppress freedom of speech. We must be vigilant against people who want to control your bodies through vaccines. We want freedom, but we want freedom for a very specific bunch of people. We don't want freedom for people who use drugs. We don't want freedom for people who are actually at very high risk of contracting a severe COVID-19 complication. We want freedom for a very specific few. So what is an Albertan to do? It's a bleak picture, isn't it? We've talked a lot this weekend about how there are specific people in our society who are very, very skilled at controlling narrative. And the disinformation formula is how it's done in the world of science. So what's an Albertan to do? I don't want anyone here to lose hope. I want you to be disruptors. Step away from your screens. There is so much disinformation online. It's not to say don't use it, but step away from it and think outside of that box and go and figure out where am I actually going to be able to corroborate the information that's getting flooded at me. Number one, ground yourself in community. Everything I do is for community. And the reason those of you in healthcare are such effective advocates, if you choose to be, is because you are an immersed witness to the human condition. You are seeing people's lives play out. You are seeing injustice. Ground yourself in those stories. Do some listening. Figure out what people who are directly affected by policy are experiencing. Help that truth to be told instead. Practice and model critical thinking, of course. We'll talk a little bit about information formulas in a minute. You have to learn to recognize what is garbage out there and how to call people out on it. Speak truth instead. Be very careful before you spread something. Make sure what is the truth, right? In science, we don't talk about absolute truths. We talk about how much certainty we have. We understand that our understanding will evolve over time, but ensure that what you speak to is defensible, is justifiable, makes sense based on what we do know in that moment. And be honest about what you don't know, but be compelling and tell that truth and tell that story with love, with hope, with caring. Use emotion, connect brain and heart. The numbers I shared, those are humans. Those are human beings. So this is a human story, backed by science. Keep caring. How do we sense make in a disinformation age? This is the critical toolkit, is recognizing what bias looks like and how to mitigate it. When I do my research, it's really, really important that I position myself. We talked about the wheel of power and privilege. I have to situate myself in the story. I have to understand that I bring bias to the table, and that's okay. I'm a human being. I have a lens. I have a perspective. It has value. It's important for me to address that and mitigate any bias I bring to the table and recognize the strength of it and also the challenges. And there are many ways as a researcher and many steps I can take to make sure that what I'm sharing is defensible and that somebody else has reviewed it, that someone else agrees with it, can understand my reasoning. So you have to position yourself and you have to reflect on how that position affects what you're talking about. I wish the government would think about that as well. But it's up to us as consumers of information. You have a role to play. You don't need to be a specialist. In fact, I think beware the expert halo, honestly. Generalism skills, folks. I'm a family doc, I'm a generalist. I specialize in making sense of complex information at the end of the day, right? But you all do. If you're evaluating incoming information and you're not a specialist of that information, then you can do this. You can put on your complex systems thinking hats. In addition to spotting and managing bias in incoming data, it's important that scientifically trained folks mitigate it. But your job is to call them out. Conflict of interest. Has that been reported? If it hasn't, figure it out. Do some work. Look around about those folks who are authoring this report. Has this stuff been peer reviewed? Has it been touched by people who weren't involved in the production of the work? If you don't see those two things, and that's very big picture, I'm starting with the big picture stuff, you gotta be very, very careful with what you're reading. We talked about confirmation bias a lot in the examples earlier, so just be very careful if the preamble of a report or the setup of the report is, I'm gonna look at this very specific thing because it's a problem, and there, see, I've proved it. You know that's gonna be a very dangerous report to read. But be careful if you're doing the same thing yourself. Make sure you don't become an echo chamber. Make sure you seek out varying positions on things when you're arriving at conclusions and generating knowledge. Recall bias, really important as well. These are more specific things, more from medical research and stuff that I've just pulled in here, but it does apply to other forms of research as well. People recounting what happened to them long ago based on a prompt, people are more likely to recall that, oh yeah, this thing happened to me, it must have been related to this thing that we're talking about. So just be very careful. One way to mitigate that is to seek a number of different data sources, right? So you're making sure that you're not just dealing with people's accounts, but maybe are there other ways to measure or document what's going on. Measurement bias, make sure that people are using the right metrics. We talked about that with the NAV Center, right? These are metrics that actually matter and that are being measured accurately rather than by hearsay or approximation. We talk about patient-oriented outcomes in medicine. That's what we're talking about. I really don't care that a referral was made so much as I care that somebody was housed, for example, right? Some other effects that you might see that you have to be aware of. The placebo effect, I think everybody understands in this room, so I won't go into that. The idea of Hawthorne effects is that you're aware that you're being studied, you're aware that something's going on, and your behavior changes as a result of that awareness. So if you're seeing these sorts of things in the reports that you're reading or in policy making, beware. And if you are developing policy piece is if you're developing research, beware. When you're knowledge generating, it's your job as well to mitigate this stuff, okay? Make it defensible. Thank you.
Thank you very, very, very much, Dr. Salvalaggio. We are going to continue our conversation asking questions.
I'd like to expand on the notion of misinformation, mistruths, and outright lies. And one of the issues I have, and I'm angry about this, is that horrible woman and premier is blaming and condemning cancer patients for contracting cancer and spreading lies, hatred, and so forth, condemning them for the condition that was probably caused by the Alberta government's horrible record on the environment, especially in the tar sands. Cases of a few years ago, there was a young person who won some award for arts, and in his speech, the Kenny government told him not to say certain sentences or whatever that were speaking the truth. What can we do about misinformation to the point? Can we actually go to court and call out the government? And why won't the LG even consider dismissing this government for lies? Because this sounds like outright fraud.
Thank you for your comments. And yeah, I mean, that's another example. Shifting the blame to cancer patients is a really tricky one. That's a good example of misinformation about who or what is responsible for cancer. I just wanted to clarify a little bit that there's misinformation, there's also disinformation. Disinformation is where you're actually going out and being very deliberate and spreading a falsehood. And misinformation is really about twisting the truth, sometimes intentionally, sometimes unintentionally. And that's another really good example of policy making that is fraught with concerns. The other thing that you mentioned was this idea about sanction, about punishment, and that's alive and well, and I agree with you. But legislating specific forms of punishment and sanction for folks who disrupt the narrative, it's a concerning trend, and we're not seeing it in the form of locking people up at this time, but we're seeing it in the form of financial sanction, academic freedom, revoking of funding, those sorts of things. We may well see other forms of it, and so it is concerning. Human rights matter. The courts are one of many vehicles, and some folks have done some of these public interest suits more to that point, right? So that is one form for sure.
Could you comment on the sort of Orwellian practice that the UCP has of naming things? So it's trying to make it sound very marketing-oriented, scientific-oriented, when it's actually the complete opposite. You know, this name you mentioned, the Canadian Centre for Recovery Excellence. Also this name with regard to LGBTQ kids, another example of a really Orwellian type of name that just does the opposite of what the name suggests.
The one that I love is how they've now weaponized the word compassion. So they're talking about compassionate intervention, which is basically a form of locking people up against their wills. And we already have vehicles for that in voluntary care for people who lack capacity. But we very, very carefully apply that, and it is the exception rather than the rule, because you are taking away someone's autonomy and agency, and most of us disagree with that. But it is an example, yeah. Weaponizing specific terms, taking over specific terms. A good example of it as well is just co-opting the Canadian flag. These are strong symbols, and people currently who are trying to control the narrative are very good at symbols. Do we have some good symbols that can push back against that? That's very, very important. What kind of image can you evoke, or what kind of idea can you evoke with words? Symbols aren't owned, like, I'm not going to call them Orwellian myself, but these ideas, these narratives, we can do them as well. And they can be grounded in evidence, and they can be grounded in what's actually happening.
I'm Graham. I was just wondering if there's any good sources that you know of, like online, for accessing data, for stuff that's like a trusted source, easily accessed, breaks down the data from different reports and different institutes and makes it more accessible for me to go to as a resource when I'm trying to just make an idea of what all the mess that's going on.
There's some observatories out there, but it's tricky. It depends, because it's very, very complicated. There's so much data. We're in a data age as well, folks, right? There are public dashboards. For example, I use the substance use surveillance system all the time. You know, Alberta Health Services has this, a bunch of metrics. There's the Canadian Institute for Health Information, more to the healthcare world. So there's different places, different holdings. If you're a researcher and you get the right permissions and stuff, you can get into StatsCan, that kind of stuff. You can enter into agreements. As far as publicly facing stuff, yeah, I mean, certainly more accountability would be better and more access would be better. Unfortunately, I wish I could tell you there was some central clearinghouse and there isn't, but just speaking with people who are immersed in that area is just one way to find that out, where you would go to data for specific questions. Some of it's available. It's not all hidden.
Something that has stood out to me all weekend is speakers like yourselves talking about the other side taking a kernel of truth or a real fear that the public has, perhaps in this case around public safety, access to their own healthcare and services, or even fear of losing a loved one to a drug overdose, or a drug poisoning rather, and then naming both false causes and false solutions to those issues. And I really appreciate the way that your presentation honored the grief and shared some data and then shared some suggestions about ways to talk about it. But I wondered if you felt comfortable modeling for us, like what would you say to someone in more like a social setting or your neighbor at a party? I had a person that I have a close relationship with me say, like, I don't know, I'm worried for those people too. I care about those things too. I'm concerned about it too. But I'm not sure that our government should be spending money on these types of services, safe injection sites, other harm reduction pieces, when I can't even find myself a family doctor. So when you've got somebody in front of you who's not got a radicalized opinion about it, doesn't hate houseless people, doesn't believe we should do nothing, but feels like, why is this a priority? Why is this the thing we should do? I'm not even sure it's working. What's the thing that you would say to someone in your life?
I think there's a couple of strategies that I will take depending on the person or the circumstance, and I think story is really important. I am scientifically trained. I'm also a family doc. I'm also a writer, as all academics are, and I think telling stories is incredibly, incredibly important. And I can talk about numbers until I'm blue in the face, but unless you are a scientifically trained person, or we self-select for that in medical school, unfortunately. Most people, they don't speak in numbers. The numbers are compelling, it's important, money's important. So sometimes public purse, those arguments are important, but story is important. And there's a lot of people who've done some work around that, about how to change hearts and minds, and that's, so if you do have a story, you can tell, and so I will, always respecting privacy, but I will talk about my cycle commute. I'll talk about how that affects me. But the other thing I will do is, I'm an amateur of complex systems. I'm certainly not an expert. I work in a complex system. Generalism is complex, and I will talk about that power and privilege wheel and talking about if you design everything for the people in the middle, if you think about normal distribution, if you design everything for the average Joe might benefit for a while, but you haven't accounted for all of the other stuff swirling around, and you have not accounted for anyone out on the edges. And statistically speaking, we're all going to find ourselves out on the edges at some point. That truly is that safety net, unless you design a system that accounts for the edges and that deliberately pays attention to the situation at the margins and designs for that, then you're going to have a system that works for no one. You start designing for the edges, everybody in society benefits. Everybody does better because you've created a system that brings everybody along. Why can't the person at the SCS also have a family doc? And I can tell you right now, it is far easier for someone to just cold call someone and find a friend, find someone who knows someone and say, you know, I'm going to get care. I'm going to figure out this care pathway somehow. You've got more natural supports. You got someone on the street, they've got no one. So I need to design a better system of primary care for that person. And that primary care might come from a nurse and a peer support worker and an SCS. So I have to design a better system of care for that person, and then everyone benefits, because then it is actually responsive to Alberta needs. So those would be the things I would consider.
I work with HSAA, Alberta Health Services, and I code charts for a living. So we send data to CAI. We are coding houselessness when we see it on charts, so please keep documenting that. We're coding a lot of emerge visits with patients coming in with drug use disorders. You know, they come in, they get triaged by the nurse, they sit there for 6+ hours, and then they leave because they can't wait for a doctor. And then they're back into another emerge the next day. So our healthcare dollars are going way up due to those reasons. They're not getting care. So we all know the system's broken. Plus, I live close to the gun center. We won't even talk about that. So my question is, there's campaigns out there. The unions, AFL are all doing this. Campaigns on social media. We urge you guys to share these campaigns. about the drug addiction, like addiction health is healthcare, right? It's a health problem that they have too. Now, but we need to get our side of the story and our stories out there to the mass public to try to drown the UCP. How do we do that? Are these campaigns working? We don't know. So, how do we get in front of media or get interviews with news reporters? Something. We need to get out there so that hundreds of thousands of people are seeing it and not just those that are watching the UCP media.
A couple of us in this room were part of the Edmonton's own Medical Staff Association Opioid Poisoning Committee. I hate it that people trust doctors more than a lot of people. But what I would say is, getting yourself in front of the mic, but there's different ways to do that. You can get in front of mainstream media, you can get in front of alternative media, you can get in the socials. You can write open letters to government, you can write op-eds, you can do all of those sorts of things. You can't do it in your own echo chamber. A lot of us are guilty of just kind of sitting in the same rooms with people who think the way we do. So you have to get outside of your echo chamber. That's incredibly important. One of my lessons learned during that poisoning committee work was building coalitions, understanding who you needed at the table. We spent a lot of time including people on the front lines and lived experience so that what we were talking about was very real and very raw and very fresh. Your story is an important story to tell. Figure out perhaps who else you need in your group, in your team, to get in front of the right people. Sometimes you'll never get in specific rooms. Sometimes we get excluded from specific rooms. And that's when you can do a little bit of agitating from the side, from the edge. And sometimes that's okay too. I know I've been excluded from some rooms now. But it's okay. Just keep agitating from the side.
Thank you very much for your work, Doctor. I remember attending a memorial for the homeless, the number of people, every year there's a memorial to the people who have died on the streets, and there were about 20, I think, at that time. And now what are there, 400? And of course the number of amputees, people who have lost digits and whatnot, was it over 400 last year? It was a lot. I'm involved with a bunch of different issues. By the way, I'm with the Edmonton chapter of the Council of Canadians. The notion of Fridays at the legislature, it'd sure be nice to see a lot of people at the legislature really demonstrating about this crisis. I mean, it's so horrific to imagine, the number of people who have lost digits and their lives. It's very heartbreaking. In terms of the media, I'm wondering, do you feel that you've been excluded from the media at all? I hope that you can bring this story to the broader media. I remember hearing some years ago that CBC is FOIPable. I wonder if it would be worth FOIPing in terms of the people who are trying to influence in a democratic or perhaps a non-democratic way access to the media, in terms of the number of people who go to the news editor at CBC asking for a story to be followed up on. And indeed, I guess all of us here could contact the news editor at CBC to ask for this kind of story to be followed up. But I was just wondering if you have any comments on or experience with trying to get access to the media.
So I know that we have someone talking about organizing in a very short moment in another room. But I would say that involves building relationships, and that includes building relationships with media, many of whom are kind of sitting in the room with us. I think it comes down to that, is just having conversations with folks. And I don't think I've been excluded, but I think it does involve fostering relationships. And we talk about that in any policy making, any storytelling, any policy making, any academic work. It's a team sport. It is about relationship, and you can't do this work solo and be effective. So no, that is one room I don't feel like I've been fully excluded. There are some newsrooms that have zero interest in chatting with me, and that's okay. I think there's a role in just fostering those relationships. I hadn't really thought about FOIPing a newsroom. That's very interesting. Interesting premise, for sure. And I do think we haven't talked about protests and rallies. They have some effect as well. I have been honored to have received some mentorship from amazing groups like Moms Stop the Harm. Grief is incredibly powerful. And hurting means you care, and just making sure that the grief is not weaponized is really, really important. But sharing those stories of grief and getting them out in media is really important. So you brought that up, and just like the memorials and stuff. It is a travesty how many people are dying out in the cold now, losing digits. So use the hurt, share the story, use it to organize, use it to advocate.
Hi, my name is Anne Goldblatt, and I had the opportunity to coordinate the planning and the advocacy for the supervised consumption services in Edmonton. And one of the strategies that we deliberately chose was to wait till late in the process to identify where the locations were going to be. And like over our 7-year planning process, there were people in the communities who, from a very emotional place, were very angry with us that we had kept it under the radar. I've thought about it so many times over the years of whether we could have done things differently, and could we have found common ground if we had opened ourselves up to some dialogue. And we've talked a lot, and you talked about echo chamber, whether it would have unfolded differently. But it was some of the things that people said were so ugly, so hurtful during that planning process that it was hard to engage. But we felt we were on the side of evidence. We had Dr. Elaine Hishka's research. We were so convinced that what we were doing was right. And so I just wonder if you have some experiences of trying to find common ground, trying to have that dialogue with people who see it from such a different place, and for whom evidence, they kind of dismiss the evidence.
And that takes deep, deep listening and an understanding of concerns, but remembering that public health is about caring for everyone in the community. When it comes to that, we have to be careful that we're not accused of suppressing, of lack of review, lack of due diligence and procedure and so on. I don't know if sharing sites earlier would have helped. We have good neighbor agreements and so on now, for example, for SCS, and I think we, as a society, opened up consultation a lot sooner, for example, for the Strathcona hub. It has not led to a site being there. It has led to the same amount of vitriol and the same amount of emotion. So having divulged earlier, I don't know if it would have helped with those relationships, but it is about relationships, and it's about relationships with all of us and everyone, whether or not someone shares your point of view. We don't have to twist, though, or bend to that will with things that aren't evidence-based. It's okay to include science. It's in your conversations, but translate the science. So it's really, more scientists need to be trained in properly translating evidence and properly mobilizing evidence such that it is digestible and such that people actually can personally relate to it. So that comes down to telling those stories and distilling them into plain language and into things that matter to people. But in order to distill it, you need to know your audience, and you need to understand their pain points, and you need to understand that everybody in a pandemic age is hurting, that society is hurting, and we're seeking scapegoats and we're seeking safe and easy answers. Sometimes that involves othering entire subpopulations who are in need, who are less well placed to advocate and hold any power in the conversation. So, it is about translating knowledge, but that's about listening and figuring out what people need to understand about an issue. Lovingly dispel myths that are contributing to their internal narrative in a way, and figure out what is in it for me in an evidence-based way, always in an evidence-based way. So here is why, if you are worried about the disorder in your community, for example, one of the things when people are talking about Strathcona, again, I'm using this because this is my world, this is exactly where I live. People are talking about, well, how would you feel if this was in your backyard? And I'm like, dude, I'm right by the ravine. My neighbor is an encampment. Like, how much closer can this be? And what I want for that person is to see them as a human being and look them in the eye and check on them when I'm cycling and make sure that they're going to be okay today, because I wouldn't be able to live with myself without it. And they're already here. And this site, you're scapegoating, and it's about helping that person be well. And so it's those conversations and gently and lovingly dispelling myths.
So we've talked about the problem and mitigating strategies and management. I wanted to know what your take is on preemptive. Like, if you look at the work of Dr. Gabor Mate, houselessness is a symptom. Addiction is a symptom. Mm-hmm. But I have an idea of what the problem is. But do you have any thoughts on how to treat these people effectively? Also, get into why the addiction, not just treating the addiction, but how did these people get there and what's going on, and then basically how to approach it.
Here's how I do my regular job, my family doctor job, is I sit and I listen to my patient and I understand their story over time. I know that there are some things that contribute to their current state. I'm very careful about not assigning a root cause analysis. I'm aware and I attend to likely risk factors for a current state, and I try to attend to them and address them for sure. That's the benefit of having a family talk. Every person's journey is unique, and I specialize in that person's journey. Were there pain points along the way that I can help with? And for some people, it's going to be mental health and trauma, which I think you were getting at when invoking Gabor Mate. For other people, it's going to be untreated pain. For other people, it's going to be a houseless state. I can tell you that people use a lot less meth when they're not trying to suppress hunger and cold, and they don't have to worry about staying safe at night. If I can deal with some of those social, emotional, physical complexities along the way and reduce someone's overall burden of health issues, I've done a lot for their well-being. But I'm also keeping an open door and offering voluntary substance use support if they want it. And I'm also trying my best to keep them alive with some harm reduction education and naloxone kits. So it's a basket. The other thing is be very wary if anyone says, this is the only policy lever we need. That's incredibly dangerous talk. We are all very individual human beings here. We all have our own story. And if we're all told that you have to be fit into this one round hole and you're the square peg, that's damaging, it's destructive, it's violent. You have a story, you deserve care that's tailored to you.
Thank you very much, Professor Salvalaggio.